Okay, good morning. Yeah, okay, fine, fine.
Hello.
So, good morning, everyone. So, today's turn is GCRI Gujarat. They are going to take the very important topic, Tumour Lysis Syndrome, which every resident will have to have a thorough idea that what exactly it is and what exactly we have to do when patients presents in emergency or in a routine, how to recognize, how to manage. So this Gujarat team, MD and senior residents, they are going to take. And Dr. Preeti has asked me to introduce Dr. Ravi. Dr. Ravi is their faculty in the Gujarat in their team, and Dr. Ravi is going to introduce our speaker and moderator today. So I request Dr. Ravi, please introduce both of them, speakers as well as moderator. Anybody has any question, please write down. We will take it last. So go ahead, Dr. Ravi. Hello.
We can hear
Hello.
you, Sushma ma'am. We can hear you.
But I can't hear Dr. Ravi, so I can introduce, then we will not waste time. Dr. Lekha is a third year junior resident, junior resident of MD Palliative Medicine at GCRI. She has got publication also, various tools for assessment of pain in International Journal of Evidence-Based Nursing, and she has presented already.
Good morning, everyone. Am I here?
Any
Dr. Lekha
yes,
is
Dr.
presented
Ravi.
by Dr. Lekha Raval, at GCRI.
Okay, I'll stop. Go ahead. Go ahead, Dr. Ravi. We can't hear you in between. So, Dr. Ravi, something is problematic in your mic, so you can stop. I'm introducing both of them. Don't worry. So, Dr. Lekha is as third year palliative medicine student, and then moderator. Who is the moderator? Moderator, just show me moderator. Okay, moderator is Dr. Mayur Ghoghari, and she is also the senior resident at Department of Pain and Palliative Medicine at Gujarat Cancer Institute. So I think the third year MD student is going to take the class, and the senior resident will moderate. Okay, go ahead. Go ahead, Lekha.
Yes, ma'am. Yes. Good morning, all. I'm Dr. Lekha Vijaykumar presenting a lecture on Tumour Lysis Syndrome. Next slide, ma'am. Topics will be covered for today's lecture are introduction, definition and classification, pathophysiology, risk factor, risk stratification, clinical presentation, prevention and evidence-based management and prevention. Next slide, ma'am. So, to introduction, Tumour Lysis Syndrome is an acute life-threatening disease among adult and children that is associated with the initiation of cytoreductive therapy in the treatment of malignancy. A pattern of metabolic derangement occurs as a result of rapid, massive release of intracellular contents into the systemic circulation. Next slide. Cairo and Bishop developed a definition as well as criteria in 2004 by dividing Tumour Lysis syndrome in laboratory as well as clinical Tumour Lysis syndrome. William and colleagues, which modified this Cairo and Bishop classification by following criteria. Laboratory Tumour Lysis syndrome is two or more of following laboratory abnormalities within 3 days prior to and up to 7 days after initiation of cytotoxic therapy, which are uric acid more than 8 milligram per deciliter, potassium more than 6 or more milliequivalent per liter, phosphate more than 6.5 milligram per deciliter for children and more than or equal to 4.5 milligram per deciliter for adult. Calcium is less than 7 or equal to 7 milligram per deciliter or 25% change from the baseline in any of above analytes. While in clinical Tumour Lysis syndrome, laboratory Tumour Lysis syndrome should be present plus one or more following things. Creatinine level equal to or more than 1.5 times the upper limit of normal, cardiac arrhythmia, seizure or sudden death. Do stamp as a Tumour Lysis syndrome. In clinical tumor lysis syndrome, when creatinine is increased, no directly or probably related, creatinine should not be other causes of raised creatinine should be ruled out. Next slide, ma'am. And Howard and colleagues in 2011 stated that few refinements could improve this classification. One of them is it should be stipulated that 2 or more metabolic abnormalities should be present simultaneously, because some patient may present with one abnormality, but later another one may develop that is unrelated to tumor lysis syndrome. For example, hypocalcemia associated with the sepsis within the same 24-hour period before or after 7 days of starting chemotherapy. Secondly, in contrast to Cairo and Bishop definition, a 25% change from baseline should not be considered a criteria, since such increases are rarely clinically important unless value is already outside the normal range. Third, any symptomatic hypocalcemia should constitute clinical tumor lysis syndrome. Next slide, ma'am. Cairo and Bishop also graded clinical tumor lysis syndrome from 0 to 5, where 0 is creatinine, cardiac arrhythmia, and seizures are not there. Creatinine is normal. In grade 1, creatinine is more than 1.5 of upper limit of normal. Cardiac arrhythmia is present, but intervention is not indicated. Seizure is not there in grade 1. In grade 2, when there is 1.5 to 3 times increase in the creatinine of baseline, then cardiac arrhythmia is present, but non-urgent medical intervention is indicated. And seizure is one, brief, generalized, or well controlled with the anticonvulsant, or infrequent focal, not interfering with the activity of daily living. In grade 3, 3 to 6 times increase in the create of upper limit of normal. Cardiac arrhythmia is present, symptomatic, and incompletely controlled medically, or controlled with the device, example, defibrillator. Where seizure is present, in which consciousness is altered, poorly controlled seizure disorder with breakthrough generalized seizure despite medical intervention. And in grade 4, creatinine is more than 6 of upper limit of normal. Cardiac arrhythmia is present, life-threatening, and seizure is of any kind which are prolonged, repetitive, or difficult to control. And grade 5 is death due to any of this. Next. When pathophysiology, when cancer cell lies, they release potassium, phosphorus, nucleic acid, and finally uric acid as an end product in human. It is being discussed under following subheading: hyperuricemia, hyperphosphatemia, and hypocalcemia, hyperkalemia, and acute kidney injury. First, we will discuss hyperuricemia, which is hallmark of TLS that, along with hyperphosphatemia, can lead to acute kidney injury. Purine containing nucleic acid, that is adenosine and guanine, released into serum are catabolized into uric acid, and when present in excess, which it surpasses the renal tubular capacity for uric acid excretion. In catabolic pathway, nucleic acids are first metabolized into hyperxanthine and xanthine, which are subsequently converted to uric acid through enzymatic action of xanthine oxidase, which we will see in the next slide. This is diagrammatic representation. When disintegration of cellular nuclei occurs with the release of nucleic acid, excess of purine metabolism will be there, and which will in turn convert into hyperxanthine, which is more soluble than uric acid, which by the enzyme xanthine oxidase, which it will convert into xanthine, and with the same enzyme, it will convert into uric acid, which is insoluble in the water. Xanthine oxidase is the enzyme which is the site of action of oxypurinol, the active metabolite of allopurinol drug. And this uric acid, it will further reduce to allantoin with the help of urate oxidase enzyme, which is not present in human otherwise, but site of action of phosphoric acid, with also we will see in the next slides. Next slide. Uric acid is poorly soluble in water, and the solubility is markedly reduced in the physiological acidic environment of distributed and collecting system. Thus, uric acid crystals readily precipitate when concentrated in the renal circulation, leading to renal tubule obstruction and obstructive uropathy, with compromised glomerular filtration and reduced urine output. Xanthine nephropathy and xanthine lithiasis can also occur in patients with tumor lysis who are receiving allopurinol, a widely used hypouricemic agent. Next slide. Allopurinol blocks uric acid synthesis through its active metabolite oxypurinol, which is xanthine analog and competitive inhibitor of xanthine oxidase. Blockage of this pathway leads to accumulation of the uric acid precursors xanthine and hypoxanthine, which hypoxanthine is more soluble and more easily excreted than the uric acid. However, xanthine is less soluble and metabolite than uric acid, and its accumulation led to xanthine precipitation. Xanthine levels are not routinely measured, and incidence of xanthine nephropathy and its contribution to AKI is in the TLS are unknown. Next slide. Uric oxidase or uricase, it is an enzyme present in most mammals that oxidize the uric acid to water soluble, readily excreted at metabolite allantoin, which is 5 to 10-fold more soluble than uric acid. And uric oxidase is absent in human because of missense mutation. But pharmacological urate oxide is available and used in prevention and treatment of hyperuricemia. Urate oxidase originally was purified from fungus Aspergillus flavus and caused frequent allergic reaction. Next slide. Raspericase is recombinant preparation biosynthesized from strain of genetically modified Saccharomyces cerevisiae containing cDNA from Aspergillus flavus that encodes for urate oxidase. Raspericase is highly effective at rapidly reducing the uric acid level without increasing level of uric acid precursor, and therefore does not risk xanthine nephropathy, which allopurinol does. Next slide. Second is hyperphosphatemia and hypocalcemia. Tumor cells often contain higher concentration of phosphate than normal counterparts, and the amount of phosphate released varies by tumor type. In massive tumor lysis, mechanism of renal tubular excretion of phosphate becomes saturated. The excess serum phosphate binds to calcium and result in secondary hypocalcemia and calcium phosphate deposition throughout the body. Hypocalcemia can range from asymptomatic to life-threatening, cardiac conduction abnormality or seizures, and calcium phosphate deposition in the heart can cause fatal dysrhythmias. Next slide. Nephrocalcinosis is precipitation of calcium phosphate crystal in the renal tubule that can result in nephrolithiasis and can cause further provoke the obstructive uropathy. The risk of calcium phosphate precipitation in the tissue increases when calcium phosphate product exceed 60 milligram per deciliter, and product of 70 milligram per deciliter or greater may be an indication of renal replacement therapy. Next slide. Third one is hyperkalemia. Potassium is primarily intracellular electrolyte that is regulated through the renal excretion. Hyperkalemia can precipitate cardiac dysrhythmia and sudden death. Calcium helps stabilize the cardiac membrane by directly blocking the effect of potassium on the resting membrane potential of cardiomyocyte. Thus, hypocalcemia exacerbate hyperkalemia, induce cardiac toxicity and cardiac dysrhythmia. Potassium level greater than 7 is generally considered as hyperkalemic emergency and can be potentiated by ongoing tumor lysis, hypocalcemia, and or renal impairment. Next. Fourth one is acute renal injury, which is independent predictor of short-term and long-term mortality in TLS, which are of two types: crystal dependent and crystal independent mechanism. First, we will see crystal dependent mechanism in next slide. Crystal-dependent mechanism includes obstructive uropathy as a result of uric acid and calcium phosphate precipitation. Decreased urine output can result in volume overload and cardiac failure. Low flow states can in turn exacerbate crystal precipitation. Alkalization of urine keeps uric acid in its more soluble ionized form and prevents crystallization in renal tubules. Next slide. Once it was common practice to alkalize urine for the prevention of and treatment of hyperuricemia in TLS. But conversely, it may worsen the renal function by inciting precipitation of calcium phosphate, which is less soluble in alkaline environment. With the widespread use of uricemic acid agent to prevent hyperuricemia, this controversial practice is no longer recommended. Next. Crystal-independent mechanisms include loss of autoregulation, renal vasoconstriction, and local inflammation. Tumour lysis-induced hypercytokainemia can result in hypertension, systemic inflammation, and multi-organ failure. Next slide. This is the overview of pathogenesis of TLS. Lysis of cancer cell release DNA, phosphate, potassium, and cytokines, which directly in turn causes acute kidney injury, and excess of DNA metabolites, that is uric acid, phosphate, and potassium accumulation occurs in the cell, and which causes Tumour lysis syndrome. Next slide. Next is risk factor for the Tumour lysis syndrome. There are major three factors are there. Disease-related factor, which we'll discuss here, is rapid cellular proliferation rate, elevation of serum LDH more than 2 times of upper limit of normal range, then high tumor burden, that is bulky tumor more than 10 centimeter, wildly metastatic disease, elevated WBC count more than 25,000 per microliter, and solid tumors with high proliferated rate and rapid response to therapy, and renal infiltration or outflow tract obstruction by tumor. Next. Second is patient-related factors. Pre-existing renal disease or uremia is there, and like in nephropathy, renal failure or oliguria, urinary tract obstruction, then pre-treatment with the hyperuricemia or pre-treatment hyperuricemia or hyperphosphatemia. Baseline uric acid is more than 7.5 milligram per deciliter. Hypovolemia or hypertension is there, or acidic urine is there. Third one is next to treatment-related factors, which is intensity of cytoreductive therapy, single agent versus combination of therapy. Disease-specific varies according to the tumor type. Inadequate hydration during cytoreductive therapy and concurrent use of nephrotoxic drugs. Next slide. Now, patient stratification. Evidence-based patient stratification was developed by the Williams and colleague in 2018. Guidelines for the prevention of adult and children depends on the risk assessment for stratifying patient as being at low, that is less than 1.5, less than 1%, intermediate 1 to 5%, and high or more than 5% risk of developing TLS. An international expert panel proposed a first risk stratification model in 2008 based principally on tumor type, WBC count, and it was updated in 2010 to incorporate all malignancy and known risk factors. It includes histological diagnosis, disease burden, age of diagnosis, particular tumor, use of particular cytotoxic agents or biological therapy, and final adjustment based on renal function. Next slide. So, high risk or more than 5% risk of developing TLS are non-Hodgkin lymphoma, Burkitt lymphoma, or B cell ALL, ALL with the WBC of more than or equal to 1 lakh, AML in which WBC more than or equal to 50,000, monoblastic type, CLL, and in intermediate type and 1 to 5% of risk of developing TLS, DLBCL, ALL with the WBC of 50,000 to 1 lakh, AML with the WBC of 10,000 to 50,000, CLL with the WBC of 10,000 to 1 lakh, and treatment with fludarabine, and other hematological malignancy with rapid proliferation with the expected rapid response to therapy. Example, germ cell tumor, neuroblastomas, that is solid tumor. Indolent low or less than 1%, indolent and ALL with WBC of less than 50,000, WBC of less than 10,000, or CLL with the WBC less than 10,000, and remainder of patients with the solid tumor not meeting the criteria for intermediate risk. Next. And other than that, rarely Tumour Lysis syndrome is associated with the administration of steroids, biological immunomodulators, and monoclonal antibodies. Agents that are associated with development of Tumour Lysis syndrome include thalidomide, bortezomib, hydroxyurea, paclitaxel, fludarabine, etoposide, and zoledronic acid. In rare instances, Tumour Lysis syndrome has been observed in patients under GA undergoing surgery, and other rare occurrence of Tumour Lysis syndrome are seen in pregnancy or high fever. Next slide. Algorithmic approach for risk assessment of Tumour Lysis syndrome. All the patients are undergoing chemotherapy should be measured for potassium, serum potassium, serum phosphorus, calcium, creatinine, uric acid, and urine output. If there is less than 1 abnormal value is present, no TLS as diagnosis, but assess cancer mass. If it is small or resected localized tumor, there is negligible risk. If there is medium size cancer mass, assess cell lysis potential, that is, if there is low, then again negligible risk. If there is medium or unknown, assess for pre-existing nephropathy, dehydration, acidosis, hypotension, nephrotoxic drug exposure. If there is that is present, if not present, then low risk of developing clinical TLS. And if that is present, intermediate risk of clinical TLS. If there is high for cell lysis potential, there is high risk of developing clinical TLS. In large cancer mass, again assess for cell lysis potential. If that is low risk, medium or unknown, that is intermediate risk, and high is high risk of clinical TLS. If that is 2 or more abnormal values are present, laboratory and clinical TLS criteria should be met. And if laboratory TLS criteria is met, then high risk of clinical TLS. And if there is established TLS, clinical TLS with the AKI and symptomatic hypocalcemia and dyspnea, established clinical Tumour Lysis syndrome is there. Next slide. Now, history and physical examination. History and physical examination of patient with TLS should be focused on primary causes of TLS. Time of onset of malignancy should be elicited with the attention like weight loss or anorexia. The presence of respiratory symptoms like dyspnea, orthopnea, and tachypnea can be sign of airway compression from primary tumor as well. Next slide. Symptoms associated with TLS. Urinary symptoms such as dysuria, flank pain, and hematuria can be there. Nausea, vomiting, seizure, tetany, and change in mental status can be there. Syncopal attack, palpitation, lethargy, facial swelling, and abnormal dissection can be there. Joint pain and colicky pain can be present. Next. Signs associated with TLS. The physical examination should focus on electrolyte abnormalities that are associated with TLS. First is hypocalcemia, which can cause cardiac spasm, pedal spasm, tetany, Chostek sign positive, Trousseau sign positive, wheezing associated with bronchospasm, and seizure. Next slide. Uremia for hypouricemia and obstructive uropathy causes weakness, lethargy, malaise, nausea, vomiting, metallic taste in mouth, irritability, generalized pruritus, raise and bronchi from volume overload, muffled heart sound from pericarditis secondary to uremia. Calcium phosphate crystal deposit in skin and gangrene. The signs and symptoms of TLS can develop spontaneously or about 72 hours after initiation of chemotherapy. Next slide. Now, the evaluation of TLS is primarily based on criteria that is already we discussed. Next, other than that, imaging like X-ray and CT scan of chest to evaluate the presence of mediastinal mass and presence of concomitant pleural effusion. CT scan and ultrasound of abdomen and retroperitoneal structure if mass lesion is located in the abdomen or retroperitoneum. Care must be taken with the IV contrast because presence of AKI in TLS. Next slide. Next is ECG. ECG is a part of workup for patients with TLS to check for findings associated with the hyperkalemia and hypocalcemia. Hyperkalemia is potential cause of fatal arrhythmia in TLS. CBC to help the diagnosis of malignancy associated with it. A hallmark of most malignancy is leukocytosis with anemia and thrombocytopenia. Next slide. Comprehensive metabolic panel to, as we know that TLS is are associated with hyperkalemia, hypocalcemia, hyperphosphatemia, and hyperuricemia. Blood urea nitrogen, creatinine, and LDH are also elevated in TLS. CMP must be monitored between 2 to 3 times daily before and after initiation of therapy. Elevated laboratory value might be indicative of beginning of Tumour Lysis syndrome. Next slide. Last one is urine analysis. Frequent urine analysis with the assessment of urine pH, specific gravity, and output is mandatory. Precipitation of uric acid salt can cause obstructive uropathy. Next slide. Now the prevention and screening. There is great deal of overlap in prevention and management of TLS are there, and both involve monitoring of fluid status, laboratory analytes, and use of hypouricemic agents. Prevention of TLS and related complication is focused on preservation of renal function and prevention and screening for the development of TLS. Prophylaxis should be started prior to initiation of anti-tumor therapy whenever possible. Next slide. Kofinger and colleagues developed the treatment algorithm for prevention of hyperuricemia based on evaluation of patient risk factor. If there is low risk, clinical judgment and monitoring should do. If there is intermediate risk, hydration plus initial management with the allopurinol, raspberry case may be considered in the initial management of pediatric patient. If hyperuricemia develops, initiate raspberry case therapy instead of allopurinol. And in high-risk patient, hydration plus initial management with the raspberry case. Next slide. Jones and colleagues developed evidence-based recommendation for prevention of Tumour Lysis syndrome, which will be defined under the 1 to 4, 1 to 5, and 8 A, B, C, D. Now, the recommendation, there are 8 recommendation. First is patient due to receive chemotherapy for any hematological malignancy should have a risk assessment for TLS. Low risk patient managed with the careful attention to monitoring, measurement of fluid status, and laboratory result with low threshold for the resource IV fluid and consideration of allopurinol if needed. Intermediate risk patients should be offered up to 7 days of allopurinol prophylaxis along with the increased hydration post-initiation of treatment or until risk of TLS is resolved. In high risk of patients should be offered prophylaxis with the raspberry case along with the increased hydration. Next slide. Fifth one is raspberry case should be avoided in patients with G6PD deficiency. Such patient should be treated with fluid and allopurinol and monitored carefully. in case of wherever respiratory case is needed. 6.1 is urine assays taken whilst patients are receiving respiratory case must be sent to laboratory on ice to prevent falsely low assay result. In high-risk adult, in the absence of established clinical or laboratory TLS, TLS can be prevented and in majority of patients using single fixed dose of 3 mg raspberry case, but this must be followed by careful monitoring of clinical and biological parameters with repeat dosing if required. Next slide. In high-risk children, in the absence of established clinical or laboratory TLS, prophylaxis can be achieved in many patients using single fixed dose of raspberry case 0.2 mg per kg. Treatment needs to be followed by close laboratory and clinical monitoring for evidence of progressive TLS. While the ninth recommendation, while it seemed reasonable to use as in adult, a fixed dose of 3 mg raspberry case, it is not possible to make a firm recommendation on the basis of current evidence. Where raspberry case is being used in the treatment of prophylaxis of TLS, addition of allopurinol is unnecessary and has potential to reduce the effectiveness of previous one. 10th one is urine alkalization is not recommendation in prophylaxis. Next slide. These were the prevention. Now the management of TLS will be discussed in the following subheadings. First is analyte monitoring, hydration, hypouric acid agents, electrolyte management, and hemodialysis, followed by evidence-based management guidelines. First one is analyte monitoring. The obtained baseline analyte values that are of uric acid, electrolyte, LDH, and creatinine prior to the initiation of cytoreactive therapy or administration of hypouricemic agent. Frequency of analyte testing is based on TLS risk assessment. For high risk, every 4 to 6 hours, intermediate risk 6 to 8 hours, low risk daily. It ultimately depends on the clinical condition of the patient and underlying comorbidities. Next slide. It is important to consider that uric acid level may remain normal in patients with emerging TLS who are administered a prophylactically hypouricemic agent. For patients who receive raspberry case, laboratories must develop protocols to collect the uric acid sample in pre-chilled tubes that are placed immediately on the ice and capped on ice through the rapid transport to the laboratory for immediate run to the instrument to prevent the rapid in vitro uric acid breakdown and spuriously low acid result. Next slide. Second one is hydration. Maintaining high urine output with adequate hydration is most important aspect of TLS prevention and management. It improves renal perfusion and glomerular filtration and minimize acidosis, all of which serve to prevent the precipitation of uric acid and calcium phosphate crystal in the renal tubules. Intermediate to high risk patients and those with established TLS, hyperhydration with the hypotonic or isotonic solution is recommended with the goal of maintaining equal fluid balance and high urine output. Next slide. Volume status must be carefully monitored to prevent volume overload and particularly in patients with renal failure or cardiac dysfunction. And if that is there, diuretics may be necessary to maintain the urine output. Loop diuretics are often favored because they promote potassium excretion, which help in the reduction of hypokalemia. And however, diuretics must be avoided in hypovolemia or obstructive urine. Third one is hypouricemic agents. First one is allopurinol, xanthine oxidase inhibitor. It blocks de novo synthesis of uric acid and it is preferred prophylactic agent in low to intermediate risk patients, but it is limited by few limitations. First is if it does not break down pre-existing uric acid. Urine nephropathy can develop in the 2 to 3 days it takes to have therapeutic effect, and it does not preferred agent in presence of hypouricemia. Xanthine nephropathy can be developed with the prophylactic therapy with the allopurinol. Next slide. Secondly, Secondly, allopurinol is excreted by the kidneys and must be reduced in the patients with renal insufficiency. Thirdly, there is high occurrence of hypersensitivity reaction in Asian population with allopurinol use. And lastly, because allopurinol reduces purine degradation, chemotherapeutic agents such as 6-mercaptopurine and azathioprine must be dose reduced by 50 to 70% when concurrently administered. In patient who develops TLS while receiving allopurinol prophylaxis should be switched to rasbericate. Second is rasbericase. It is recombinant urate oxidase that converts uric acid and metabolite of nucleic acid to highly soluble form of allantoin. It is highly effective at preventing and treating hyperuricemia. It is preferred prophylactic agent for patients at high risk of TLS and treatment of choice for established TLS unless contraindicated. Unlike allopurinol, rasbericase rapidly reduces uric acid level without therapeutic delay and breaks down deposits of uric acid. Next. It also reduces serum creatinine and phosphate level. It is generally well tolerated and does not require renal dosing, but it is contraindicated for pregnant and lactating women, patients with G6PD deficiencies because of risk of severe hemolytic anemia and methanohemoglobin. Patients should be screened for G6PD priorly, and there is risk for severe hypersensitivity reaction such as anaphylactic reaction and particularly with the repeat dosing. Next slide. Evidence-based administration of anti-hyperuricemic agents are dosing recommendations are for allopurinol dose is 100 milligram per meter square per dose every 8 hours or 10 milligram per kg per day per oral. Maximum 800 milligram per day can be given or 200 to 400 milligram per meter square per day in 1 to 3 divided doses. IV can be given. Maximum is 600 milligram per day. Dose should be reduced by 50% in renal failure. Reduced dose also the dose should be reduced also in case of 6-mercaptopurine and azathioprine concomitant administration by 65 to 75%, and it may need to adjust dose of dicumulose diazetics, chlorpropamide, cyclosporin, or allopurinol when they are used concomitantly with allopurinol. In the case of rasbericase, dosing are intravenous doses over 30 minutes should be given. For low risk, 0.1 milligram per kg. For intermediate risk, 0.15 milligram per kg. And for high risk, 0.2 milligram per kg is being given. Uric acid level should be monitored regularly and used as a guide to modulate dosing. An average duration of therapy is 2 days, but it can vary from 1 to 7 days. Next slide. Fourth one is electrolyte management. Hypercalcemia and hyperkalemia and hypocalcemia. Patients with hyperkalemia or hypocalcemia should be placed on cardiac monitoring and have repeat analyte testing every 4 to 6 hours because of risk of fatal arrhythmia. Serum potassium level greater than 7 to 7.5 milliequivalent per liter or widening of QRX complex requires immediate intervention, and standard therapies to reduce potassiums are loop diuretics, insulin with glucose, inhaled beta agonist, polystyrene sulfate, and calcium gluconate for symptomatic hyperkalemia or ECG changes. Next slide. Asymptomatic hypocalcemia should not be treated with calcium administration because of risk of increasing calcium phosphate deposition in renal tubule. Symptomatic hypocalcemia should be treated at the lowest dose to the point of symptom relief, but not to normalize the value of calcium. Hyperphosphatemia is treated with phosphate binders. Next slide. Fifth one is hemodialysis. Indication for hemodialysis include refractory volume overload, oliguria or anuria is there, persistent hyperkalemia or hyperuricemia despite above measures, hyperphosphatemia induced symptomatic hypocalcemia, and calcium phosphate product of greater than 70 milligram per deciliter. Next slide. The need of hemodialysis appears to have been reduced since addition of respiratory to induction therapy. Prophylactic hemodialysis in patients at risk of TLS may be appropriate in the setting of pre-existing renal disease or AKI at presentation, and further studies are needed. Next slide. These are evidence-based recommendations for treatment of established TLS, already discussed prevention guidelines by the same author. There are total 12 recommendations are there. First one is management of established TLS require multidisciplinary approach with the involvement of hematologists, nephrologists, and ICU physicians. If facilities, second one is if facilities are not available at locally intensive management and for locally intensive management and monitoring, considered to be consideration should be given to the transfer of the patient to an intensive care or high dependency facility or to hematological center, offering higher level of care as defined by BCSH criteria. Balanced or isotonic solution should be administered to keep urine output more than 4 ml per kg per hour for infants and 100 ml per meter square per hour for older patients. Fourth one is potassium must not be added to the hydration fluid. Next one. Alkalization of urine is not recommended in the treatment of TLS. Sixth one is allopurinol, while useful in prophylactic setting, is not drug of choice in established TLS except in the presence of G6PD deficiency or allergy to raspberry cane. In the absence of contraindication, patients with established TLS should be given raspberry cane at the dose of 0.2 milligram per kg per day as 30-minute infusion, and duration of treatment should be determined by the clinical response. Seventh one, asymptomatic hypocalcemia should not be treated. Eighth one, symptomatic hypocalcemia should be treated with a short infusion of calcium gluconate at dose applicable to the age per weight of the patient, and close monitoring of calcium level, phosphate level, and renal function should be there. Ninth one, patients with potassium level more than 6 millimole per liter or having experienced a 25 increase in potassium level from baseline should have cardiac monitoring. 10th one, injectable fluid overload, hyperkalemia, hyperuricemia, and hyperphosphatemia or hypocalcemia are indications for renal dialysis. Peritoneal dialysis is not recommended for treatment of TLS. And last one is dialysis should continue until there is adequate recovery of renal function, resolution of severe electrolyte imbalance, and recovery of urine output. Thank you.
What happened, Archana? Is it over?
Yes,
ma'am.
Okay. So, Lekha. So, would you like to take up the question answer? Any query? Can't see anything.
Nothing at the moment, ma'am.
Anybody wants to share their experience in this on this subject? Dr. Jennifer, would you like to say a few words about this subject to audience? Dr. Jennifer, Dr. Shobha, as a palliative care physician, what are their responsibilities?
Hello, good morning. This is Shobha here.
Yes, Shobha, go ahead.
Yeah, I think it was, covered properly what you can do at the time of this happening. But so most of the time when they are actually having chemo, the oncologist would take care of this phenomenon. But towards the end of life, once the treatment period is over, you might not have allopurinol and things like that given to them. And it's also sometimes futile to treat hyperkalemia in such patients, other than just to protect the heart, you give calcium gluconate, because towards end of life care, you might have at that point in time Tumour Lysis syndrome. So you have to look at it as you would look at any sort of symptom towards end of life care. But it's a good practice to sort of keep track of this, hydrate the patient, and remove the distress. So we don't want to cause any arrhythmia and push them towards the other side. That is what we need to keep in mind. So this is mostly treated by oncologists, and we have some say in the matter in the sense towards end of life, whether we actually want to give allopurinol or not. So most of the time, the creat and LFT and things like that are not amicable for us to treat properly. So we need to probably look at it as an intractable symptom and treat accordingly. Just to protect the heart, maybe we would give calcium gluconate. But to bring the potassium down, it doesn't work. If you give dextrose insulin infusion, it might not work. And but for placebo effect or for our sake of the feeling that we have done something, we put them on Astelin, nebs and things like that. So that's our practice normally. We would explain to the family members what is happening, and make sure that the patient is comfortable. So that's what we do. Thank you.
Thank you, Shobha. Thank you very much. Dr. Stanley, would you like to add, or Dr. Jennifer?
I think, yes, our role as palliative care people in this condition is mainly based on the prognosis. If the prognosis is short, like if it's in weeks, I don't think we should just consider it as a terminal event and just keep the patient comfortable with all the end-of-life care measures and not go into aggressive management. So aggressive management, depending on good prognosis, longer prognosis, the oncologist will take care. But our role would be later if it is very, prognosis is short. Thank you.
So thank you. I think, yes, Dr. Jennifer, go ahead, please.
So thank you for the good, very nice presentation on identification and management. I think as palliative care physicians, is again very important for us to know because again, this is an oncological emergency. Like mentioned by Shobha and Dr. Stanley also, this is something which needs to be aggressively treated while they are in their radical or curative phase of treatment. And so it is important for us to identify, and it is best probably managed by the oncologist. However, having said that, the more we are talking and doing early integration of palliative care within oncology settings, it is important for us to figure out when a patient comes sick, not to attribute the whole thing to disease, but keep a lookout on certain malignancies which you already mentioned, which have a high risk for tumor lysis, so that we identify and do the relevant investigations and quickly refer them for treatment. Also, in patient education, while on oncological treatment, is an important aspect about hydration and about what risk factors or what signs or symptoms they should be looking for in this group of patients. So I think these are some of the points that are relevant to us as palliative care physicians when we co-manage these patients with oncologists. Thank you.
Thank you, Dr. Jennifer. Anyone wants to have any comments? Otherwise, I just want to say to all the residents and all the young palliative care physicians that Tumour Lysis Syndrome is as Dr. Jennifer said, is an important entity, which all of us should know, right from the pathophysiology to the treatment. And most of the time, it is in a reversible condition until unless prognosis is very poor. So as we have learned in palliative medicine, that we will try to reverse the condition, and most of the time reversible situation will come when you will use interdisciplinary approach. This is basically most of the time whenever there is basically resident should know recognition of the condition. So you should learn that suddenly if a patient is presenting in delirium or any symptoms which Lekha has presented nicely, you must try to do as best as possible till the oncologist reach. So that's why it is important that because in I don't know other situation, but in AIMS, if a patient is presenting with certain symptoms, which as many a times palliative care physician is the number one doctor who is looking after these patients. And once we realize that this is the situation, then we call oncologist. So the early integration will happen only when we will learn these type of situation, when we will learn how to manage these situation, and when we will learn what are the trigger factors which patient when we should stop this. Like, it is important that we should learn that also, but most of the time it is not that it's only end of life. Yeah, it's a purely a reversible situation. And if as last slide, like I said, that it is also important that we should know that whether intensive care facilities or critical care or high dependency care facility is available, because for some time patient may need high dependency care. So thank you very much, Dr. Lekha. I always say that all palliative care physicians should have a thorough knowledge of everything what is happening in oncology or palliative care situation, and you should know everything about Tumour Lysis Syndrome. So thank you, Dr. Stanley, Dr. Jennifer, and Dr. Shobha. We all, and Lekha, thank you very much. Dr. Ravi, I don't know what happened and we missed you. We could not hear you. So if you are here, then it's okay. Otherwise, we'll stop here. And thank you, Mayur. Thank you very much. It was a good presentation by Lekha and you. Thank you very much. Mayur, you want to add something?
Hello. Hello, ma'am.
Yes.
We are using febuxostat as allopurinol, and respiratory is not cost effectiveness at based on palliative patients. Hello.
Okay. Good. Okay then. We all will see you.
Hello.
हाँ Mayur बोलो. Yes, go ahead.
Ma'am, we are using febuxostat to treat hyperuricemia, as respiratory is the not cost effective.
Okay, fine. Thank you very much. Thank you, everyone. See you next week before 6:30. Thank you.